Shall we start?
Yes, sir.
Okay. So thank you very much for joining on the second day of Dr. Advani's legendary oncology series. And in the current scenario where we are still reeling from the COVID pandemic, especially when you look at the Western Europe and North America, where they have a huge second wave, we have none other than Dr. Advaita Gore to take us through this first topic. So Advaita, over to you.
Thank you, sir. So, thank you, Dr. Advani, sir. Thank you, Purvish, sir, for making us meet over this virtual platform and have a very interesting discussion. Look forward to all the lessons that we've learned in this lockdown. I'm going to focus on CML and COVID and looking at the top three lessons that we've learned. Now, moving from yesterday, where we discussed about what has happened in CML over last 7 years and how the change in the ELN 2020 guidelines have occurred. These are the gist of it. Essentially, we look at second generation TKI in frontline therapy. The risk assessment has improved with the UTOS long-term survival score, the ELTS score, and there is improved monitoring with RQ-PCR by international standard being available in most of the centers and has practically replaced doing a bone marrow and cytogenetic response assessment. We are also talking about deep molecular response on basis of the RQ-PCR with MR4 or MR4.5 on the international standard scale. And the goal of therapy now has changed to a treatment-free remission. These guidelines were published in March of 2020, and little we know that at that point of time we would be hit by this COVID wave. It started in December 2019, and we know that the conventional routes of transmission were through respiratory droplets from the infected patients, touching surface or object that has the live virus, and then touching to mouth, eyes, or nose. GI tract, saliva, urine, these still remain unconfirmed routes, and symptomatology of these patients also was very variable. I want to share a case vignette which happened with me. This was my first experience handling a patient with COVID directly. So this was a 45-year-old lady whom I had first seen in August, September 2019, who had presented to me with fatigue and ecchymosis. Clinically, she had pallor, few ecchymotic patches, a 5 centimeter palpable spleen, and a 2 centimeter palpable liver. Blood count showed low hemoglobin, total count of 1,63,000 with a classical differential count showing a shift to left with myelocytes, metamyelocytes, and 6% blasts. So as initial evaluation for any chronic myeloproliferative disorder, we got her FISH done and RQ-PCR done, which came positive. And marrow showed a chronic phase CML with grade 3 fibrosis, karyotype also confirming translocation 922. After discussion about second generation or first generation drugs, she was started on imatinib in September. At 1 month mark, she achieved complete hematological response with a normal CBC and the resolution of spleen. January, at 3 months interval, BCR-ABL was down from 40 to 5%, which was a good response, and she was continued with the same drug. In late March 2020, she presented back to us with severe backache, and she had already been to multiple physicians, orthopedic surgeons, spine surgeons, and the last spine surgeon that she met had asked for an MRI which showed a diffuse altered marrow signals in the dorsal vertebrae and many other parts of the spine. So she was hospitalized for pain management, and there we got a count done which showed 54,000 counts with 33% blasts. And as the hospital where we practice had a protocol of doing COVID testing for all patients who are hospitalized, her COVID swab came out positive. Eventually, she was transferred to a COVID care center. CML was in blast crisis, which were mainly lymphoid. From there, she was transferred to another tertiary care hospital in the government setting. But unfortunately, there was a progressive drop in platelets and patient landed up with pulmonary hemorrhage and succumbed to this. So this just opened up my mind to look into what all things have been evaluated and discussed. And we come across this study from China. This is from the Hubei province. 530 patients, which was a questionnaire-based study, showed a 9-fold higher prevalence in the study population as compared to normal individuals. And the risk factors, which this Chinese group said that there was the primary risk factor being exposure to another COVID-infected person, patients with comorbidities, patients who have not achieved a complete hematological response, or patients in advanced phase CML. even if they were in complete cytogenetic response or major molecular response, were at higher risk of developing COVID-19. There was another Dutch prospective cohort study which was published in Leukemia. This was based on the See My Life Dutch population registry portal. This was an online study, and they essentially looked at a cohort of patients which were matched with controls from their own household for age as well as for geographical location. And this study did not actually find any prevalence of COVID-19 in higher prevalence of COVID-19 in CML patients who were on therapy. Another interesting study from Turkey looked at outcome of these COVID-19 patients in CML receiving TKIs. And this was 16 lab confirmed COVID-19 patients receiving TKI. They looked at the age, gender, comorbid disease, and they matched these COVID-19 patients to other patients without cancer in 3:1 ratio, total of about 48 patients. There were lower rates of ICU admission, lower rates of mechanical ventilation, lesser hospital stay, and a lower case fatality rate in CML patients. And they attributed this possibility to TKI because there have been preclinical data which mentions that ABL kinase inhibitors do prevent the viron fusion with endosome, thus blocking the viral entry and replication. There is also inhibition of IL-6 and other pro-inflammatory cytokines, and there is improvement of the pulmonary endothelial barrier dysfunction. That was the primary reason why there have been multiple trials looking at TKIs even in managing COVID-19 patients. Now, this data was just published about 2 days back. This is from the International CML Foundation. This is a registry data called the CANDID study, where the primary goal of the study was to actually rapidly collect and analyze information of these COVID-19 cases among CML and look at prognostic and risk factors. And from March of 2020, an anonymized case collection form was sent, and patients' forms were reviewed, cases were tracked by the data manager, and from 20 countries they were able to the report published 2 days back mentions about 110 cases from 20 countries. Majority of are from Europe, 15% from Asian continent. And this showed that when we look at the table A, I know it's a tiny one, but patients who are having comorbidities had about 13% mortality. Patients who were early during the CML, that is within the first 1 year, there was 33% mortality. Patients who had TKI interruptions, either because of COVID diagnosis, had a higher mortality of 23% versus 5% in patients who did not stop their TKIs. And patients who were on imatinib or other therapy apart from TKI had a higher mortality. We see that patients who were on other therapies, almost 50% mortality is shown, although the numbers are less. Patients who were on imatinib, there were 32 out of these 87 patients who were on imatinib. There was a mortality of about 25%, while the second generation TKI, 29 patients were noted of the 87. So mortality was only 3% in these patients. As per the age distribution criteria, if the patient was less than 65 years of age, there was a good survival probability of 88% even post-COVID, but this really went down to only 50% in patients who were more than or equal to 75 years. So mortality rate from COVID-19 in the CML patients was about 13%, and the two factors which emerged was imatinib therapy and age greater than 75 as a higher risk factor of death due to COVID-19 in these group of patients. We've really been bombarded with multiple guidelines, lock, unlock, multiple different guidelines for COVID management, also from authoritarian bodies, ASCO, NCCN, ASH, as well as ESMO. And I've tried to put a gist of all the guidelines which are there currently for common questions which may come up to us as clinicians. So the first question was, is it advisable to change treatment recommendations for a newly diagnosed CML during the COVID era? So most of these guidelines do not recommend any change in treatment. We would continue to treat newly diagnosed CML patients and look at the diagnostic evaluation and choice of therapy the same way as what we would do without the pandemic. The caveat here is that the initial period of myelosuppression should be monitored very closely, and the treatment related neutropenia should be minimized. So prophylactic use of growth factors is advocated. There is no current evidence that any of those TKIs do pose a greater or a lower risk of COVID acquisition or a worse outcome, though we have this International CML Foundation data which says that imatinib may be one of the factors by which these patients were having a poor mortality in this group of patients. Should treatment be changed for those patients who are already on treatment? The answer again to that is no. Patients who are asymptomatic and do not have any documented infection don't need any treatment. uh, we need to be careful for patients who are having COVID-19, especially with certain drugs like dasatinib, where pulmonary arterial hypertension and pleural effusion are common, especially in the accelerated phase or blast crisis patients. In chronic phase patients, we see that less commonly, so the second generation TKI can be given, and the adverse management should be continued as per the standard practice. Patients, those who have developed COVID, should the CML therapy be stopped, or do we need to do any dose adjustment? So the CML patients who are in TFR, those are the ones who have stable deep molecular response and they are off the TKIs, and they need to be managed the same way as what we would do for general population, even once they become infected with COVID-19. In presence of a non-severe COVID-19, treatment interruption is not really necessary for patients who are ongoing with TKI therapy. For patients with severe COVID-19, interruption of TKI can be considered on a case-to-case basis after a multidisciplinary team approach. Discussing with the pulmonologist and the ICU care team is extremely essential, because many of these drugs do have cardiopulmonary toxicity, and essentially those who develop COVID-19 infection, we would need to stop the TKI until both the infection and the adverse event can be resolved, because many a times pneumonitis and other pulmonary complications, they may overlap between these two. Looking at any interaction between the current CML treatment and what other therapies have been tried for SARS-CoV, it is very clear that convalescent plasma, corticosteroids, or remdesivir can be used safely. There is a caution in using hydroxychloroquine or azithromycin because of drug-drug interaction, especially when TKIs are co-administered with these, because we need more stringent ECG monitoring. We need close monitoring of electrolytes, particularly the potassium and magnesium levels, especially with drugs like nilotinib. And none of these four frontline drugs, including bosutinib, actually have any interactions with remdesivir. So the conclusions after this extensive evaluation was that yes, the ELTS score has been helpful in predicting the rate of death from CML. However, with the COVID era, we really have to be very cautious. Molecular testing from blood is practically replacing the cytogenetics in most of the situation, unless we are dealing with a scenario where the patient has progressed on initial line of therapy and we need to look out for additional cytogenetic abnormalities, where obviously we need additional bone marrow evaluations. Offering second generation TKIs in the front line has a higher chance of deep molecular response and TFR. And to sum it up, the three take-home lessons here is that yes, we should optimize first-line therapy, looking at the International CML Foundation data, probably using second-generation TKIs upfront, now especially when the availability of dasatinib generic is also there in India. It is really going to increase the use of second-generation TKI. During the COVID-19 pandemic, we don't need to change any of the treatment recommendations. Of course, all measures to avoid the risk of COVID transmission are necessary, and they need to be counseled to all our patients. There should be an element of suspicion and early detection and appropriate therapy in all cases, especially focusing on patients who are elderly. In our scenario, I would look at patients who are more than 65 years of age, because most of the patients, at more than half of them, do have comorbidities, and patients who are in advanced phase of CML, like accelerated phase of blast crisis. And in a scenario like ours, TFR should be offered only in selected cases where there is going to be a completely unhindered access to molecular testing. Otherwise, I would recommend that the patient should continue on the drug till the time that COVID pandemic comes under control, and then the TFR can be looked into. Thank you very much.
Thank you so much, sir, for the wonderful lecture. We'll move on to our next session. The session moderator is Dr. Himant Malhotra, medical and hemato-oncologist from Jaipur. His panelists are Dr. Ajay Bapna, hemato-oncologist from Jaipur, Dr. Rishabh Kothari, medical oncologist from Ahmedabad, Dr. Dinesh Burani, hemato-oncologist from New Delhi, Dr. Avinash Popfuli, hemato-oncologist from Nagpur, Dr. Chirag Shah, hemato-oncologist from Ahmedabad. Hemant sir, please note, Dr. Abhay will not be able to join us. Over to you, sir.
Thank you very much, Kashish. Can you hear me?
Yes, sir, loud and clear.
And is my screen visible?
Not yet, sir.
Oh, how do I do that? I did.
So you'll have to click shares. Sir, you'll have to click on the tab. I'm not sure if you.
Share screen.
Just 1 second. Where is that tab partner share screen? Okay, here goes.
Yes, sir. We can see your screen.